Welcome everyone to today's webinar. I am Leo Bartarella with Becker's Healthcare. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a recording of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Cheryl Huey joined Connecticut Children's Medical Center in 2011. Major accomplishments include developing a shared governance model for nursing, implementing a nurse residency program, launching the Nurse Leadership Academy, partnering with quality colleagues to implement a culture of safety program in conjunction with the Connecticut Hospital Association statewide collaborative, and collaborating with UConn School of Nursing to develop the Institute for Nursing Research at Connecticut Children's. Cheryl was the labor team lead on their Managing Value and Performance initiative and presently leads an organization-wide approach to improve the patient experience. Karen Webb brings over 25 years of clinical leadership experience for emergency departments. As a consultant for Philips Bluej Consulting, she helps providers to implement ED best practices to improve operational performance while enhancing the patient and staff experience. Her work in performance improvement has translated to several magnet documents. Karen became an interim ED manager for Connecticut Childrens in 2015, working with Cheryl and the team. The initial contract was for 13 weeks, but the impact was significant, and she stayed with them for about 2 years. Cheryl, I'll now turn the floor over to you.
Thank you so much, and good morning, everyone. I'm so happy to be here today to partner with Karen to let you know our story and all the exciting work that we accomplished together. So let me give you a little history about Connecticut Children's Medical Center for those of you who do not know us. We are a 187-bed, nationally recognized, not-for-profit facility located in Hartford, Connecticut, and we are the only freestanding children's hospital in the state that's dedicated exclusively to children. There are about 36 freestanding children's hospitals left across the country, and we are one of them. We have about 1,000 plus providers, about 2,600 employees. We have an ambulatory surgery center and our other half of our NICU located across town about 10 miles away. We have a 12-bed med-surg unit that's located about a half an hour away. And we have about 17 or 18 other clinic facilities and other care treatment centers located across the state of Connecticut. We are a level 1 pediatric trauma center, and our 38-bed ED supports 61 annual visits. We do have 11 of those beds dedicated to our behavioral health population. It is not an inpatient unit, it's just a place where we try to stabilize and then make sure that we triage them to the appropriate place. We do have our teaching affiliations with UConn and Quinnipiac University, both in physician and nursing connections, and we are a research partner of Jackson Lab. You can see we have in the top 50 of our cardiology, heart surgery. We've been ranked in U.S. News and World Report. We are a national leader in community-based prevention. We have an incredible Office of Community Child Health that's been has nationally recognized programs, about 13 of them, and we are in about 26 states across the country. This is a really very big program for us, and we are considered the leader in community prevention and wellness. We are very much in our growth strategy at this point. Connecticut Children's is really expanding their coverage across the state of Connecticut. It's a very exciting time to be here at Connecticut Children's, and we are on our magnet journey. We have submitted our document, and we're awaiting site visit as we speak. So next slide, please. So I guess the question really is, how did we come to partner with Philips Bluej in the first place? Well, about, let's see, 3 to 4 years ago, we found ourselves really taking a look at our ED volumes and processes. So our volumes were increasing year over year, putting a bit of a stress on our systems. Our wait times were going up. Our patient-family experience wasn't where we wanted it to be. And on top of that, we experienced a safety event, and that safety event really galvanized us and forced us to look at our processes, our procedures, look at our how we were leading, how we were taking a look at our employees, everything around our ED, and we knew we were going to need some help with that. There was a community perception of long wait times. Our left without being seen rate wasn't where we wanted it to be for sure. And then we looked at overall patient satisfaction, and of course we wanted to improve it. We know that EDs, traditionally have a hard time with patient experience and keeping their experience where they want it to be, but we want it to be better in that space. So in the end, we really wanted to create something sustainable, something consistent, something that we could count on carrying us into the future. And so we definitely needed assistance with that. Next slide, please. So we looked for additional resources, and we took a look at Philips Bluej, and I think the part that really put us over, and I talk about us meaning myself and my partner, Dr. Juan Salazar, we obviously looking to increase the operational efficiency and patient throughput. That was number one. We wanted to make sure we were getting patients through our system efficiently. We also had an ED leadership vacancy. I had a director in place but needed a manager in the ED. But we were also looking for sustainability. And prior to my coming to Connecticut Children's, we had 2 other companies here, spent a lot of time and energy putting things in place, but could not seem to sustain it. And I think our mantra this time around was we needed to do this and do it for the final time and really make sure that whatever company we hired, we were going to make sure that they had a sustainability plan. And we actually did end up building that into our contract. So when we talked to Philips, Karen Webb at that point stepped in as ED manager. And she was, of course, providing day-to-day operational and staff management, but also the PI recommendations. She came with a lot of background and a lot more skill set than a manager. And we knew that it was going to be, something that she could bring to Connecticut Children's. We also asked them to deliver a comprehensive assessment of our ED operations, and that included not just our operations, but our leadership team as well, a team-based approach to PI, absolutely. And then really they delivered implementation of new processes to improve communications, staff development, rounding. She's going to be talking about all of this and all the things that Philips delivered to the table. Basically, we were looking for tools and rigor, and I think that's exactly what we found. Next slide, please. I think I'll turn it over to Karen at this point. Karen, you want to talk a little bit about what are the things that we worked on together?
Sure, thank you. Thank you, Cheryl, and thank you, Leo and the Beckers team. I really want to shout out and say thank you for the opportunity to talk about the great work and partnership that we had collaborating with Connecticut Children. So one of the first things we started work with was the triage and the front end process improvement. Some of the things that we did there, we realized that front end and triage were 2 very distinct work groups, but were very interdependent upon each other. The work that we do anywhere that we go, and specifically at Connecticut Children's, is really a team-based approach. We don't come in with a book and say this is what we need to do. We really survey the department, survey the organization, understand what is important to the client, and then we build a team. So we built a team, a multidisciplinary team of nurses, techs, physicians, ancillary support, environmental services, and looked at all aspects of this. And it was really broken into 4 different distinct teams. Triage was one end, front end process was another, charge nurse development, and then patient throughput. And we're just going to talk a little bit about each of those as we go along. So from the registration process, the team agreed that the patient needed to be moved swiftly to a room where they could be seen by a provider. Once we all decided on what our guiding principle was, which was patients came to an emergency room to see a physician. They didn't come to sit in our waiting room. They didn't come to wait. They came to see a physician. And how we both efficiently and swiftly move those patients back so that they were available to a provider. We used a lot of lean techniques. We used process mapping and really identified where the non-value added steps and barriers were to the patient registering upon arrival, and found there was a lot of movement. So consider yourself with kids, because when you're a mom and you have a sick one, you don't always come by yourself. Struggling in the chilly winter up in New England with a baby in a winter bonnet or a stocking and everything that goes along with that, and being asked to come to one place and move to another and move back and forth. We really understood a lot of movement that was difficult to navigate for a family with children. We created a quick registration process. Direct vetting was the guiding principle. The process of registration was evaluated, and it identified that the patient process for registration, they were completing an entire registration. So they weren't just getting the patient in the computer ready for the staff to take care of them. They were doing all of the stuff that is important on the back end to make sure that you could bill completely for a patient, but they were doing that on the front end. And we also realized that there's some challenges that are unique to the pediatric population. An adult arrives in an emergency room, I can tell you usually what my first and my last name is, probably can tell you parts of my social security number and definitely my date of birth. But with pediatric registration, oftentimes we were coming with grandma and grandpa. They didn't always know what first or last name, was it hyphenated that the child arrived with? And then social securities are often used in many of our processes to identify the patient and match them correctly behind the scenes. And we don't always have a social security number early, and I definitely cannot remember what my kids' social security numbers are. So those were some of the challenges that we found in the quick registration process we need to work through. Regarding the triage protocols, we found that they were not there. So there were two different policies that were in place. They were really not regulatory compliant, nor were they safety focused. So we really deep dive into that and made sure that nurses were not determining medical care. They were working at the top of their license. They were implementing processes that would provide value to the patient if they had to wait for a provider. We identified when these processes could be put in place if the patient had to wait, really lengthening the time that a nurse had to but had to implement this from maybe 10 minutes up to even 45 minutes to an hour. So staff nurses, we had a staff nurse and a medical champion that worked on this and presented it to our collaborative where we gained consensus from the physicians and did a fair amount of training and teaching that went into place. And so one of the other front-end processes that we implemented was direct vetting. And I go back to the previous comment about the safest and the best place for the patient and why they were coming was to be in a room so they could see a provider. We established the path when we had beds that were available. And then as we all know, at a certain point during the day, our emergency rooms become saturated and there's no longer beds. So we had to make two different paths and keep in mind the varying times of the day and the volumes that we would see. And we found that our technicians were really key to making the movement of the patients to the room as quickly as possible, and even had to define when vital signs would be done and by whom and how that handoff and that communication process took place. We identified that we did not have an RN in triage 24/7. And this was really critical to the safety aspect. You don't know what you have walking in the door, but to put that parallel process with a patient access staff and a dedicated RN in triage 24/7 was critical. And then we identified that at times, and for our purposes, were 11 o'clock in the morning till about 1 o'clock in the morning, we would need to have 2 nurses and a tech up there. And we worked with staff for them to understand that while the nurses in the back had a finite number of rooms, you will laugh because we have hall beds and 4 goes up to 6 very easily, but that was very different than what the nurse in the front would see if they had a waiting room full of patients. They could have anywhere from 1 nurse to 20 patients. And so once we really got this team to understand safety and being able to manage that patient load, that it was important to take that into consideration.
Karen, if I could just for a second, the direct vetting was a real sense of point of pride for the staff once they really did understand what we were trying to change and introduce the concept of we do not want a waiting room, and they saw how their direct interaction played into that. That was something that they embraced pretty quickly, and I think was one of the most easy things to sustain afterwards.
Yeah, thank you for sharing that. That's absolutely true. The other part of our front end was looking at Epic. the templates that had been built. We used Epic as the platform for the electronic documentation. And as it was built, it was not built with the flow that we had in mind currently. And we identified, I believe that we had like 45 different unique questions that were being asked before a patient could even pass the threshold and come back into a room. And so with the help of the staff, we really looked at what was important. And all of it was important, but when did it need to be asked? When was the critical or the crucial point in time that it had to be asked? What did a nurse need to know in order to make the decision on where to place a patient? So that was really very important and breakthrough. The staff really were the ones, again, that embraced this. They know the work. They told us what they needed to know in order to move a patient to the safest place for them in the appropriate room. And they helped us move from 40 to 30 different questions down to 5 questions that were asked and documented on in a quick, rapid manner. Triage was aligned with the ESI guidelines. While the hospital already had ESI and had adopted that as what they used for triage, we did identify that we needed to retrain, we needed to increase the number of staff that were trained, and we used that as a launching point. We used staff to train the trainers. We took high-performing staff, we tested the entire team, and then used the high performers to help revalidate and educate the new staff. And then one of the other things that was included in the ESI training and the triage training was establishment of an inter-rater reliability and validation process. So it's great that we trained people, but we needed to make sure that we were sticking to what we said we were going to do and that we were not finding drift in our ESI levels. So we adopted a process in which we utilized our charge nurses to help monitor and provide coaching for that. So I think we can move to the next slide. So as I spoke to the inter-rater reliability, charge nurses were really crucial and key to all of the successes that we saw. This was a team process. The PI team as well as the interim leadership were just the barrier removers, the people that helped the staff understand what needed to be done. And like Cheryl said, as soon as they identified and understood what we were striving for, they really embraced it and helped support the processes. So we looked at a very large group of charge nurses who all had great strengths. Some of them had development opportunities, outlined what the expectations were, where we wanted to go, and who was going to be part of that. And really, it's very difficult to manage a group of 22 people that on any given day were a charge nurse, and then they were side by side with the staff the next day. So we pared down the group, which was not an easy feat because it could be a sensitive subject to some people, but it did help improve our communication because we had a smaller group that we were able to meet with on an every 2-week basis, provide development. They helped set the standards. They helped us decide what we were going to do, and then they would hold each other accountable for those decisions. We used, I'm sorry, go ahead.
No, Karen, I was just going to continue again and just say this was a great example of setting a standard pretty high and seeing staff step up to it. I think sometimes we don't often allow staff to work at the top of not only their license, but their interpersonal relationships and other things. And this was creating this small group of people that were really running the ED.
Correct, right. We could not be there 24/7, so we needed to delegate that authority and stand behind them when the decisions were made. And I think it really was and can be a model for leadership succession planning and pipeline. So that's great. We did use some of the charge nurse training that Connecticut Childrens had, but then we also brought with us from a Philips perspective some charge nurse training curriculum. And what's great about that was we have a whole library of education and training that we can provide. And not everything that was in that library was applicable to this group. So again, as opposed to being a manual where we say, here, take this and do all of this. We said, this is what this team needs, and we're going to customize the training to that. We used standardized data and analytic processes through a visual metrics board. And so I had lots of different opportunities in the department where we were feeding the staff and the charge nurses information so that they could make decisions rapidly and as things started to move and change. So, you know, oftentimes we would look at a data element and it's in the past, and what are you going to do about it now? But we used NEDOCS and had that work with our Epic platform and have a board in the emergency department that is a visual board for anybody, even the patients that would walk through and if they cared to understand what it would say, but it would talk about where we were at that moment in time, and it refreshed every 5 minutes. We used that to help us guide huddles, and so we would say, instead of getting behind the 8 ball, if we meet X level on some of our metrics that are constantly being fed to it, the nurses, we need to pull this group together and huddle to see if we can make a difference. And oftentimes we found that by addressing a problem when we met a certain level, we could turn it around. And not all the time. Occasionally we would come across situations where, you know, the bus would unload literally with 20 patients and you just can't recover from that. But using the tools that were there and then enhanced helped the nurses make decisions, helped them communicate with the physicians, and pulled the team together to work together to say, how are we going to solve the problem that is at hand right this minute that we see is coming. We implemented a shift handoff. The organization embraced lean, and I do believe that we actually implemented one of the handoffs first before some of the other lean processes took place. But we would pull the staff together at the shift change. We made some changes as to who should be leading the shift. It had been primarily a nurse that was going off, and we would find oftentimes that nurse, we just had a really rough shift, not always really able to rally the troops and be positive. By making the simple change from the oncoming shift leader leading her team or his team for the shift huddle and providing the metrics, we were able to make lots of changes there. We would talk about what our goals were, where we had been, and what we were going to do. And this was oftentimes a great opportunity to talk about the quality metric of the day, the patient experience discussion of the day, update very quickly. It was meant to be more than 5 or 10 minutes. You could also sometimes see, oh, gee, we had 2 left without being seens where we've not had any in the last several days. Can anybody think about why that happened? So we were doing real-time problem solving. And then we also provided coaching and methodologies to assist with resource management, change management, managing those crucial conversations, and the conflict intervention. That was some of the training that we brought to the table. Slide, please. So we did have to embed education and communication. And again, we brought stuff and tools with us, but we also used what Connecticut Childrens had there. So we developed some education for all clinical staff. That was really the triage training. We customized that and used that to help develop our triage processes. We implemented a staff assignment board, and this was one of our, I don't know if it was our failures, but it was one of those ones where we learned and we changed course very quickly. One of our physicians said, gee, I come in and I don't know who the new nurses are, so I want pictures next to the names of the nurses on the assignment board so I know who to go look for. So the pictures weren't really great. People changed their hair. And it was not always very often you were able to correlate the person that was on the floor working, but we did come up with a staffing board that put teams together and was logical, and we talked pictures up to not really being able to work, but I do know that they have talked about reevaluating that in the future. We talked about the daily huddles for the providers and the pre-surge. This was just not a nursing initiative, and I think that's what's important. Nursing cannot do this without our physician partners, And we would bring our providers to every table at every meeting. We would bring them to every conversation. We would bring them to every huddle. We had our residents attending our huddles, which, you know, is unheard of. Were they there 100%? No, absolutely not. But our medical director, Dr. Pang, really did set the expectation that if you could be there, you needed to be there so you could hear what was important and what was happening. The improved staff and leadership communications, we talked about the patient everywhere. There was many meetings where I would bring a baby and put it in the middle of the table, and we wouldn't talk about me or you or I. We would talk about the patient and what is important for the patient. And if you were the patient, what would you want? And that really was very generative in helping staff come up with what they wanted, because many of them had been there in those shoes before, taking their child to an emergency room or been on the other side. That was actually one of the things that our shared governance team developed and implemented, was a staff shadow, where new staff and even our physicians would sit in the corner of a room with a patient and not be clinical, but be the fly on the wall and observe what was going on. We did increase peer-to-peer accountability. We would not have somebody come to me as the leader and say, I want to tell on Sally. It would be, let's bring Sally to the table and we're going to have a conversation. We needed to really start being able to have those conversations real time. Was it perfect? No. And is there always still room for improvement? Yes. But having those conversations and making them feel like they had the ability and the authority to do that was really key. And then just enhanced trust and professional relationships between the staff and the leadership. It was really very important to say what we were going to do and follow through and provide that communication. You know, not every suggestion that was put out there was something that we were able to accomplish. However, we did really want to start focusing on the closed loop communication, and that was another thing that happened at our daily huddles. Next slide, please. So our third bucket was throughput, and that included the patient experience. And we, again, used lean principles. We process mapped what happened from the time you got into a bed until the time that you left, and all of the opportunities for a barrier that could slow down that process. So we looked at lab, we looked at radiology. We wanted to understand what those factors were that could stop the patient from moving. We know that the evidence supports patients that have an ED experience that is up to 2 hours usually are more favorable on their surveys, whatever survey that you're using. And we wanted to really try and drive that home and eliminate as many barriers as possible. So one of the things we did is we visited the lab. So we did a Gemba walk, basically, right? It's great for us to sit with our lab partners and hear what they do. But when you go over to the lab and take a tour and understand that when I put my specimen in this bag and it goes through the tube system and it lands here, what happens next? It was really eye-opening for the team. We found that all of the lab specimens dropped into one area, and while the emergency department was stat or urgent, my specimen may be at the bottom of the pile that was just delivered and we didn't get to it. So it was a simple mechanism of identifying a bag, a different colored bag that was visually appealing to the lab. They would see that color blue bag and they would pick it preferentially over all of the other specimens that were in there. Because we know that they say they do the critical care in the emergency room first. How did they identify that those were in that pile? So simply changing the color of the bag helped us turn around our lab times and eliminated some of those barriers. One of the other challenges was the x-ray communication. When is a patient ready to go over to x-ray? Is it before or after the lab work? Is it before or after the IV? So we really needed to enhance the communication between the radiology team and use the tracker with a comment section for us to help them be more efficient, right? Every time they had to walk over to the emergency department to see if that patient in room 2 was ready to go to x-ray and find out that we were still starting an IV that stopped them from doing their next patient. So it eliminated the unnecessary trips, not only for the patient in the front end, but for radiology and some of our ancillary partners on the backside. Implementation of a suture cart or any type of procedure cart is one of the other things that we identified and put into place. These are just such simple little things that you can do. But we know from a perspective which patient is going to need wound care or sutures or glue or dermabond or whatever you're using at that point. What we were finding is the patient would be placed in the room and we would say, oh, you've got something that's going to probably need sutures. We would leave the patient in the room. The physician would come in, decide that the patient needed to be dermabonded or have the glue applied, which is usually a one-person thing, but would have to come out, find somebody, have them bring the equipment into the room or go get it themselves, and that would slow down the process. So implementation of a simple bedside suture cart, wound cart that had all of the necessary supplies, and again was regulatory compliant, locked, for no needles or anything like that, open and available, really helped. So when a patient with a wound was wheeled into a room, we worked with the staff to make sure that they understood the importance of bringing that cart to the bedside so that it could be used by the provider immediately, so that when they left the room, all they needed to do now was to discharge the patient. In the patient experience, we developed a rounding process to enhance the inpatient experience. Unfortunately, there comes a time in the winter where we all are having to board patients for even short amounts of time, and we knew that our patients that were spending time in the emergency department were not having that much of a positive experience. Again, partnered outside of the department. This was not a siloed approach, but we used our patient and family experience team to help us round. We set up rounding expectations with our leadership team. We got comfort bags, toothpaste, mouthwashes for moms and dads. We made sure that they had guest trays, that breastfeeding moms that were there were making sure they were getting their nutrition. We provided meal passes so that you could step away. We ensured that we got the right bed to the patient. So, you know, it's not great to sleep on an emergency room stretcher for very long. And if you're going to have to spend an amount of, we would cohort patients. We would bring the right nurses to the bedside. Cheryl was a great partner and had a great vision that we needed to bring the right nurses to the bedside. And we used our float pool when they were available. And I think that was a huge staff satisfier and patient satisfier, because those nurses understand some of the things that happen when you're in an inpatient much better than what an ED patient would do. And so I think it was just a great partnership all around to do the rounding with our leadership, the inpatient project to bring those things to the bedside. And then this is another great example of where our team came and said, hey, we have an idea and we see a barrier and we'd like to talk through it. And that is the vital sign process. So if you could flip to the next slide about that. So kids that arrive in the emergency room, we have a large spectrum. We have the not sick, ESI 4s and 5s, up to the very, very sick. And we know that about 50% in the wintertime of our patients that were arriving in the emergency room were really minor care office type visits. And these patients, there was a delay because the vital signs were taking too long or they were not completed due to patient discomfort. Again, talk back about that 2-year-old that doesn't want to get out of their snowsuit and you have to get them completely undressed, and then they don't like the tight cuff being put on the arm. So they asked staff at our collaborative to go to the literature, to go to the evidence and say what's going on. And they used the American Academy of Pediatric guidelines and identified that under the age of 5, I believe, patients in medical offices for routine visits or just sick visits weren't getting blood pressures. So the question was, why are we doing blood pressures? Is it really necessary? We used the AAP guidelines for blood pressure measurement and really defined what the non-acute patients in our setting was. And we implemented a new process, and the vital sign issue really dissipated. And you can see on this slide how we reduced the vital sign completion time, which our goal was 15 minutes, but we were averaging before this 18, and we decreased that by 17%. There were some patients that we knew that would come in for a cough, cold, a little laceration that did have some medical comorbidities, and they would need to have their blood pressure checked, right? Just as I'm there because I have a laceration, but I have an acute kidney condition, I still probably need to have my blood pressure checked. Because we weren't doing vital signs up front, we were doing those in the room now. We had the opportunity to do a complete comprehensive review of the patient's medical history and understand what was going on and make sure that we would do that. So the nurses were able to retain the autonomy to obtain a blood pressure at any time if they felt that a patient needed it or if they fell into certain parameters. So that was a really great initiative, grassroots-led staff initiative that really had some positive impact. Next slide, please. The last thing I want to talk about quickly is the further innovation to support our increased volume. So we had an abrupt increase in our patient volume in the spring of 2017. We saw unprecedented volumes, and Cheryl alluded to some of what that structure in that department looks like, our 11-bed psych safe rooms. We were the destination of choice for a lot of patients with behavioral health and mental health issues, and they were overwhelming our emergency room. And because of our daily operations brief where we would huddle together and people were aware of what the goals were, it was apparent like on day 3 or 4 of going from 0 left without being seen up to double-digit left without being seen rates, or days where we had had days with none, and we were now seeing anywhere between 10 to 20 because the patients were having to wait for so long because we were saturated. We needed to do something really different, dynamic, and quickly. So we pulled together quickly stakeholders from the entire organization. This included IT, dietary, EVS, engineering, lab, radiology, and said, we have a problem. We don't know when this is going to go away because the 2017 flu season was pretty bad, and we had it coupled with this behavioral health emergency that was really coming to a head. What can we do? We were losing our entire minor care area, which was 8 beds at that point, to the use of psych patients, and we were not being able to see our sick patients. So we found an alternate care area, and we used the continual improvement processes and principles to figure out how we were going to make this work. And literally the team came together in a 7-day period of time, identified a space, had work orders implemented on what we needed. Pharmacy found us a medication dispensing team. Materials management collaborated with us to stock and supply the rooms. And we created a minor care area that added 11 patient care rooms. And we had a surge space. We used radiology, which was adjacent to the emergency room, and that was great, except for we weren't really able to use that until 5 or 6 o'clock in the evening when their normal operations shut down because they were using the space. What we needed was a space that we could have all of the time when we were normally operating our minor care services. Because if we waited until 5 or 6 o'clock at night, we were too far gone and we were not able to come out from underneath of that burden, and then it was just a cascading effect. So we created minor care. It was fondly called 2G on the 2nd floor in an unused clinic space, and I understand not everybody is able to have that space, the luxury of space, but we were able to have that, and we shared it. We co-shared it with our urology clinic. Some days they needed a couple of our spaces. Other days we were able to use all 11, but I think it was a great demonstration of a collaborative effort and understanding flex spaces to meet the needs of patients.
And just to jump in again, that space is currently still in use. We have not gone back to give that up yet. We are finding that, the volumes are still there in the main ED, and it does make sense to separate. The only issue with that space was that it was a floor above, and so we had some difficulty getting patients and families there, but we still found a way with escorts, et cetera, to get them up to the right place. And that space, we are very tight for space overall in our organization, and a lot of people taking a look at that just recently, vacated space, and we're vying for that. But the organization realized that the ED is the front door, and we needed to make sure that we were getting the kids in that we needed to get in. So
2G is a great place. So next slide, please. So the results achieved, I'll just talk briefly about this. We did see an improved ED performance. We reduced arrival to triage by 80.5%. That went from, down to 10 minutes. Our left without being seen rate was decreased by 55%. We saw 1 month where I think we had 0.2% of left without being seen. While many people are happy with the 2%, this organization was not. They said that any patient that came for services that left without receiving the services or the care that they needed was one patient too many. So that was really great direction from the organization to ensure that we were really addressing that left without being seen. We had vital sign work, and with the help of one of our physicians and one of our nurses in the emergency room, we submitted a poster to the 2017 ENA, Emergency Nurses Association annual conference, and we had a poster presentation where we interacted with nurses from all over the country and talked about our great work with the vital sign work. All of what we talked about today helped me realize at one point that we were doing some really great things, and if you look at what the Emergency Nurses Association does with its awards, they have a Lantern Award that is very similar to the Magnet Award, but only specifically to the emergency rooms. And I remember the day that I went to Cheryl and I said, so I think that we've got this in the bag. I'd really like your permission to apply for this designation. And we were very pleased to be awarded that in 2017, and we took a contingent of nurses to St. Louis in Missouri and received the Lantern Award on behalf of Connecticut Childrens, which I think it was really good for the staff to see that the work is the work that we do every day, and we translated it into the recognition special that we were doing. And I think that helped set us up really well for the Magnet contributions from the emergency room. There was a lot of work constantly going on, and several of the things that I just highlighted were really what translated into Magnet documents in the emergency department. But again, it really set the premise up that we're not doing anything special. We're not doing work for a designation. We're doing work for the patient. And if we're doing work for the patient, let's showcase it and talk about it in our Magnet document. So I know that those sources of evidence came in from the emergency room and really contributed to the Magnet document that they have submitted. I think that's the last slide.
Mm-hmm.
So
Thank you, Cheryl and Karen, for that fantastic presentation. We will now begin today's question and answer session. Please submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We will try to get through as many questions as we have time for. Now, our first question is, you mentioned the change in the triage template. Will you share what was included in the new triage?
So we asked, I'm going to try and do this by memory. We did presenting complaint, a nurse's chief complaint, we did pain assessment, and we did the language, because you really need to make sure that we're talking to the patients in their preferred language to meet their scope. And then the last element was the ESI assignment. So stated complaint, the nurse's assessment, the interpretation, pain, and then the assignment of an ESI level.
Yes, Karen, you got it. That was it.
Thank you so much for clarifying that. Are there any behavioral health beds exclusively used for behavioral health issues, or do they flex based on demand?
Want me to take that one, Karen? Yep. They do flex on demand. We created that space with the knowledge in mind that the ED census, flexes up and down, and that the behavioral health census flexes. So it is a space where a back 4 of those 11 are strictly safe rooms. The others we created with garage doors behind, with all the equipment behind garage doors, basically set it up for flex space for sure. I will tell you that a good majority of the time with the population of behavioral health kids increasing, that we are using it for behavioral health, but we have been able to use it as flex beds.
Thank you. Is one of the 2 triage nurses directly greeting the patient upon check-in?
So yes, this is Karen. Yes, so what we have is a parallel process. We have a patient access person that asks the name of the patient and the date of birth, and side by side with that person is a nurse that is then following up with what brings you here today, and really does those quick 5 questions, does a visual inspection. If they need to, they will oftentimes pull out a stethoscope to listen to a set of lungs. Otherwise, they try and move the patient quickly to the back to their primary nurse or the secondary triage nurse if there's a wait. But yes, there is a nurse out there eyeballing every patient as they arrive.
Very helpful answers. Thank you both. And how much of a change was with the registration process specifically?
Go ahead, Karen.
I'm sorry, I'm not quite sure I understand. So how much of a change was registration? I think it was pretty significant. They were really, they were used to taking patients and doing full registrations before a medical screening exam was done. They were used to having them sign for consent up front. They were used to asking for co-pays up front before a medical screening, and they were doing the full registration. And there was a lot of coordination and collaboration that really needed to take place. Our patient access leaders and team were probably one of the most embedded team members from the outside to the emergency department that were part of this, because it was very difficult logistically to determine when was a patient ready for patient access to go in and do more. And really, it did impact their workflow, right? They were doing everything up front and only had to touch a patient once, whereas now we were asking them with the same amount of bodies and staff and FTE, patient twice or maybe even 3 times, depending on what was going on. So I think their workflow was significantly impacted. I don't have them here, but I know that the leadership when I was there was very positive about the changes. Again, it was very different, and we had to work through things that were different, but in the long run, it was a better product.
And I think it also made sure that the registration folks felt that they were actually part of our patient experience.
Yes.
Before, it became a touch point and that was it. At this point, they actually started to have relationships with the patients and families that were coming back more often. And it was often the registration person that would remember them, and it was often the registration person that would greet them. And it really made a difference in their engagement.
Well, and I think the other thing that's important, thank you for reminding me, we leveraged them as part of our patient experience. We were getting gigged from a patient experience perspective that there wasn't enough things for children to do, and something that pediatric hospitals struggle with on that question. And they would wheel their workstations on wows on, and they were part of our patient experience team in the department as well. And they embraced the idea of having a menu on the back of their computer. So while they're interfacing with mom face to face, their computer is to mom or the patient, and we use that as an opportunity to say, would you like something to do? And here's a menu of things that we can do. So again, to Cheryl's point, they were really part of the team that was helping make a difference in the patient experience.
That's great. Thank you both so much. And what were some of the triage protocols that you implemented, and how did you meet TJC requirements for protocols?
Do you want me to take that one too?
Yes, start, and I'll jump in, yes.
So we did Tylenol for pain. We did, I'm trying to think, very limited x-rays because, again, the question focuses on TJC requirements and not having nurses work outside of their practice or prescribing medicine. It was very defined. And so I guess we'll take the nausea and vomiting. If you, we would have a protocol for nausea, and you had to meet the criteria of 3 episodes of less of nausea or vomiting in the last 24 hours, and not less than the age of 2, and not greater than this, and no pain and no fever. And if you hit any of the exclusion criteria, you were not included. So it didn't touch every patient, but there were a fair amount of patients that we were able to get some of the treatment started. We did work with the asthma protocol. We do have a pretty good asthma pathway that would allow for the Dexcon and an albuterol neb if you met certain criteria to be able to do that. The pain was one of the ones that we addressed, and that one is tricky, and I understand where the questioner is coming from with that. How do you decide if you're going to choose on Tylenol versus Motrin? We took that away. The medical staff agreed upon that the preferential medication would be Motrin, and if you needed something else, then you needed to see a doctor. So we took away that choice.
Thank you very much. So how do you assign ESI without vital signs?
That's what every nurse asks every time. And if you go, and that was why the fundamental training of triage was very important, because you don't need a set of vital signs to establish what the ESI level is. Only in cases where you are a 3 and you need more information to decide if that patient is actually a little bit sicker, do you need a set of vital signs? We didn't say you couldn't do them. I will say it was probably the biggest struggle because nurses were really married to, I need the set of vital signs. But if you look at the true training and the education that goes along with that, the set of vital signs only come into place in a level 3 if you need more information. We all know what's sick. We don't stop to get a set of vital signs on a patient that's coding because we know that needs to happen. And so once we got over that hurdle, I think it was easier. But every place I go, that's the first question that they come up with.
I also think it's, the journey in there has really been teaching nurses about evidence-based practice and how many times, whether it's the ED or not, we are doing things because we have always done them. And, being part of, asking the questions is really the important education for them, the whys behind why they're doing things. And when we started to look at operational efficiency and they started to ask more questions about these whys, it became evident that they also would understand that some of this has been just history, and that we would go to literature and we would understand. And then the next question they would ask, they would already be saying, I found this article and I took a look at it. And so that the culture was moving from automatic to definitely questioning what we were doing.
Yeah, that's a great point.
Thank you both for those very helpful answers. Next question is, triage to bed, who assigns the room? The triage RN or the charge RN? Do they assign a physician to a patient in geographical area?
So that's a couple questions. So the triage nurse was really the person that assigned beds, and we did multiple different ways of doing that. We had a list about rotating because you didn't want to overwhelm. We evolved through the process to more of a team-based approach, so 2 nurses with a set of rooms, and we would share, and that also translated to our physicians. I think that is very important. Our assignment board really started having us think about keeping the care team together, the nurse, the physician, the tech, and the resident team in one geographical location. But we also tried a couple times, and it worked well. Oftentimes a little bit more staffing dependent, but when you have 2 nurses in triage, you can do this. But the use of a flow coordinator, but your front end person was saying, this patient needs to go here, and because they could see the entire emergency department, they could have an idea of, well, this patient in this room, I remember seeing them. It looks like they're sick. This new patient can go next to them because this nurse can absorb it.
Thank you. And how do you incentivize nurses to step into leadership roles such as charge nurse? Is there a financial incentive?
We actually do not have a financial incentive for charge nurse at our organization. That's something we actually have been starting to toy with, but we do not. I think it was, this generation is really into professional development. They wanted opportunities to do more or something in addition to their bedside care. And when Karen was talking earlier about, this large cadre of charge nurses that were doing it, never really, I don't think, assessed well for capabilities. And this time around, it became something to strive for. They had to really almost apply for these charge nurse positions, not quite the way we think of apply, but there had to be a real crucial conversations about those that wanted a leadership opportunity. And given the fact that we've narrowed it down to, very few at this point, enough to run the department 24/7, but it really was more of a professional development opportunity for them when presented with what they were able to do, what they were supported to do, and given the autonomy to make the decisions that they wanted to make down there. That's really what the incentive was. Anything to add there, Karen?
Well, I think that really covers it nicely. They really wanted to be part of the change and really embraced it.
Thank you both. It looks like we have time for one more question. This is, hi, we are working on lean processes in our ED. Have you worked on streamlining processes for collecting medication history on ED patients? We find it a very labor-intensive and cumbersome process.
Want me to start with that one, Karen? Okay, so we find it cumbersome as well. And we haven't found the exact answer, but we did use our continual improvement team to do a process for us down in Zone C, which is our behavioral health area. We started there. That seemed to be the most cumbersome because of the amount of medications that most of the patients had when they came in and all the reconciliation that was happening. I hope I'm answering the question correctly here. And we did do, the process and worked it out, and in the end came up with the answer of some kind of additional resource role, a tech, a pharmacy student, a pharmacy somebody that would be embedded in the ED that would actually do most of the med rec, with the physician signing off on that. But we did not pull the trigger on that. We're still taking a look at whether that is the best way to go. But so we have not nailed that.
Thank you. Well, that is all the time we have for today. I want to thank Cheryl and Karen for their excellent presentation and Philips for sponsoring today's webinar. Enjoy the rest of your day, and we look forward to having you join us for future webinars.